The next presentation is entitled Serum Biomarker Panel Outperforms the Canadian Computed Tomography Head Rule for Diagnosing Traumatic Intracranial Injury, presented by Dr. Robert Welch, Wayne State University School of Medicine.
Well, good morning, and thanks for everyone for hanging around for this. I'd like to thank my co-authors. I was funded, as were the people with a red star next to their name, by Banyan Biomarkers Incorporated in the U.S. Army to do this research, and Mr. Weber was an employee of Banyan Biomarker but is no longer employed there. So as a background, a serum biomarker panel used to predict the absence of CT findings in patients with mild to moderate TBI consisting of glial fibrillary acidic protein and ubiquitin carboxyl terminal hydrolase L1 received FDA approval in February of 2018. As this audience is aware, the Canadian CT head rule is a clinical decision tool which was published in 2001 with a primary outcome to predict the need for neurosurgical intervention and a secondary outcome of clinically important CT findings. It has been, as demonstrated, slow to be implemented in the U.S., although it has gained traction over the last few years. The primary objective of this study was to evaluate and compare the test characteristics of the biomarker panel and the CT rule for CT head findings among patients with only mild TBI. There were some secondary objectives, but it will not be presented here. The main study was a multi-center alert TBI study which enrolled patients from December 2012 to March 2014 and included suspected non-penetrating TBI patients greater than or equal to 18 years of age. They had to have a GCS of 9 to 15, and a CT was done per usual care at each of 15 US and 7 European study sites. CT and blood draw had to be completed within 12 hours of injury. We excluded patients with stroke or other neurodegenerative diseases, or if we were unable to get valid consent or determine injury time. There was a few other exclusion criteria you can see here. The CT images were interpreted by 2 subspecialty board-certified neuroradiologists who are blinded to the clinical findings and, when needed, adjudicated by a third. Concentrations of the biomarkers were determined by chemiluminescent ELISA, performed at 1 of 3 independent core labs by blinded personnel. IRB was approved at each site. For this study, we only included patients with a GCS of 14 to 15 and did a sub-analysis with GCS of 15 only. And the patients in this study had to conform to the CT rule inclusion criteria, meaning they had to have loss of consciousness, amnesia, confusion. They could not be on blood thinners, and no post-injury seizure. We pre-specified cutoff values for the biomarkers, as you can see here. And to be negative, meaning a CT was not indicated, both biomarkers had to be negative, below the cutoff value. If either one was positive or both, then a CT was indicated. And this is directly from the Dr. Steele's article, The Canadian Head CT Rules, which you're familiar with. We defined pretty much any intracranial traumatic hemorrhage as positive and also looked at some other things such as non-hemorrhagic contusions, herniations, edema, etc. We did not include CT findings of isolated skull fractures as a positive CT. We also did a sub-analysis where we looked at clinically unimportant CT findings as determined by the Canadian Head CT rule, and we had a neuroradiologist re-review all positive CTs to be sure that our assessment of this was correct. The biomarker panel and the Canadian Head CT rule were compared to gold standard CT for both all study-defined positive intracranial CT findings and then again for clinically important CT findings versus non-important or negative findings. We determined sensitivity, specificity, negative predictive value, and exact 95% confidence levels. This is the flow chart for inclusion. The main study included 1,959 patients. We excluded those with a Glasgow Coma scale of 9 to 13. 330 who were on anticoagulants or antiplatelet agents were excluded. Another 671 subjects with no loss of consciousness, et cetera, were excluded. And this resulted in 919 patients for the main analysis here. Of the 919 patients, 67 or 7.3% were CT positive, 61% were male, and a little over 13% were greater than or equal to 65 years of age. The age range was 18 to 97, and the average age was a little bit higher at about 50 years of age in the CT positive versus the negative group. Most were white, 64%, and falls accounted for about 47.6% of the injuries. Not surprisingly, loss of consciousness was noted in about 78% of the patients, but among CT positive patients, it was 85%. Post-traumatic amnesia was also quite high at 59%, but also 85% among CT positive patients. This is something I want you to remember. We had 94% of our patients had a Glasgow Coma Scale of 15, so the vast majority were Glasgow Coma Scales of 15. So for the main results, we had 67 positive CTs, as I alluded to earlier, and looking at the Canadian CT rule, if we would have applied that, we would have missed 20 patients. This resulted in sensitivity of 70% with a lower confidence interval of 57.7%. Negative predictive value was 95.5% with a lower confidence interval of 93.8%. Specificity was 55.5% here. Looking at the biomarker panel, the sensitivity was 95.5% because we missed only 3 patients, with a lower confidence interval of 87.5%. Specificity was lower at 38.8%, and this remained true throughout the rest of the analysis. Specificity was higher in the Canadian CT rule. Negative predictive value was 99.1% with a lower 95% confidence interval of 97.4%. When we looked at GCS of 15 only patients, there was 55 positive CTs, and interesting enough, all the missed CTs in both the biomarker group and the Canadian CT head rule group were in the Glasgow Coma Scale of 15 group of patients. This resulted in slightly lower sensitivity and negative predictive values for both the CT rule and the biomarker assay. However, in the biomarker assay, we still retain a 99.1% negative predictive value. Now turning to looking at only clinically significant CT findings, there were 52 of those. So that means, of the 52 means that there was only, those were the clinically significant ones. If they were clinically insignificant or negative, they were then considered negative. The sensitivity here for the Canadian CT rule was 71.2%, and for the biomarker assay was still 96.2%, retaining good negative predictive value. So for our main analysis, again, 7.3% of the 919 patients were CT positive, but if we applied the biomarker decision to determining the need for a CT scan, we would have only scanned 585 patients and resulted in 10.9% positive cases, only missing 3 patients. This study has a number of limitations. I say it was a semi-planned analysis because we prospectively collected the data to determine this Canadian CT rule, but it was not a primary objective, and it was not in the main protocol that this was a predetermined secondary analysis. I think it's important to note that the Canadian CT head rule was determined by mostly research assistants, often in conjunction with treating physicians, but we only used a checkbox to say did they, what their age was and things like that. So I suspect there might be some misclassification of the Canadian CT rule, and we included Glasgow Coma Scale of 14 for this main analysis. I also think there was some time-related limitations. We could not always determine if the Glasgow Coma Scale was really 15 at 2 hours post-injury because some people came in after the 2 hours. There was study-related delayed in blood sampling, and this may have allowed the biomarkers to rise, which if you caught these patients really early, let's say 1 hour post-injury, maybe the GFAP wouldn't be high. We know from previous studies, though, that UCHL1 usually is high early and drops down really quickly, whereas GFAP rises over the first 6 hours, and that tends to stay high for at least 24 hours. And we only enrolled patients up to 12 hours, where the Canadian CT rule allowed up to 24 hours. Far beyond the scope of this talk is the implications of a positive CT versus a clinically important CT. We also noted that the sensitivity for any injury was much lower in our study than the original study, being 70% in ours and about 92% in the original study. We have to acknowledge that loss of consciousness and disorientation was not always witnessed. We tried to determine that, but it was kind of unreliable data, so we used self-reported loss of consciousness also. There's been improvements in CT imaging technology, and interpretations by neuroradiologists as opposed to local radiologists may have found some injuries that probably we didn't see in 2000. And in the Canadian CT rule, only 67% of the patients got a CT, so it's likely the other third, there would have been some CT positive that were clinically inapparent and missed. Other studies, however, have described lower sensitivities, particularly international studies. And when we look at our numbers, it's kind of at the lower confidence interval of what other studies have quoted. As has been previously talked about, it's been somewhat difficult to implement the Canadian CT head rule. In 2004, when they tried to use it, they actually found that it increased CT use, but they were using skull x-rays often as a screening for obtaining a CT. In 2010, at 6 interventional and 6 control sites using cluster randomization, they actually increased CT use in both the intervention and control sites. Just recently, a study out of the Kaiser system was published, which looked at 13 non-trauma EDs in patients in a general database type design. So, we don't have a lot of specifics about it. And what they found with the Glasgow Coma Scale was less than 15 and over 10% of both pre and post. So a little bit higher probability group, I would think. Pre-implementation, however, they only found 3.5% head bleeds and 4.8% post-implementing the Canadian CT rule. So we were already much higher. Our baseline was much higher and would have been much, much higher if we would have applied the biomarker rule. This just came out online in March of 2019, and this was done independent of our group, but used the alert TBI data. And what they found doing a cost-effectiveness analysis was if you looked at mild TBI patients with a probability of intracranial bleeding of about 10.4%, the biomarker screen is cost-effective at $308 or less per test. Now that seems a little bit high to me, so I really need to delve into this article a little bit more and see, look at their methodology. It probably is not cost effective for moderate TBI, just no reason to screen those patients. This just reminds me, and you probably can't see this too well back there, but this is a kind of a timeline of cardiac biomarkers. And for those of us who were practicing years ago, we started using CK and LDH in like the 70s. And it's taken us 40 years to get to high sensitivity troponins. So to think that this is the final answer for biomarkers and brain injuries, we certainly know that's not true. But I think the implications of this is the clinical Canadian CT head rule published in 2001 has been difficult and still trying to implement at many sites as shown previously. The biomarker assay panel, on the other hand, appears to objectively be able to decrease CT head utilization with high sensitivity is cost effective. But I want to emphasize that I really consider this exploratory in nature because it really wasn't designed to answer this question. But I think we need to start somewhere, and when we implement these biomarkers in clinical practice and future research, I'm sure we will modify and learn more about it. Thank you, and there's a very brief reference list that you can't see.
Thank you, Dr. Welch. Abstract's open for questions. First, Mike.
Hi there, it's Ian Steele from the University of Ottawa.
I knew this was coming.
I was a bit involved with the Canadian CT head rule, and I mean, we always welcome opportunities to lessen our dependence on unnecessary testing and scanning and whatnot. So in that regard, I'm always pleased to see new initiatives. What I'm really baffled by is how you could come up with a sensitivity of 70% for the Canadian CT head rule when our own study, we validated it in JAMA in 1995, found like 99% sensitivity for important injuries and also for surgical intervention, which maybe you've got that data somewhere. And that's been replicated by numerous other studies. The sensitivity always over 95%. So I'm trying to wonder or figure out how you got it so low. And I'm understanding the physicians didn't actually use the Canadian rule, right? They didn't have it in front of them to check off. You had people going back, non-MDs going back retroactively to try to see if what the rule said?
No, it was the data was usually collected, and I'll tell you, it varied from site to site. And for example, in my case, it was done by research assistants who were trained and doing all this. Now, it was prospectively collected, and oftentimes it asked the physician, but you're right, we did not have a checkbox in front of us to do this. What I would say is, yeah, it has been prospectively validated in many studies, but other studies, as you know, have shown slightly lower,
Well, nothing like 70%. Yeah. That's unheard
No,
of.
that's, I said, so that's the lower 95%.
So that's unfortunate.
That's some of the low ones.
I would suggest, as you're obviously wanting this to be adapted, this new technology, that you do ultimately compare it to the other prospectively performed multi-center studies. That would be my recommendation. Not that you need to listen to my advice, but the other thing is, though, of course, this is new, but you suggested maybe it's $300, and so to me, it's all about avoiding like a $100 CT scan. So are we making progress? Because it's going to take time to do the blood work, and so I can anticipate some feasibility issues. Could you comment on that?
Yes, I totally agree with you there. That if after 17 years we were using this rule consistently, I'd totally agree with you. The problem that I believe they have is they've not yet developed a really clinically useful platform to have a rapid answer for these tests. It's in the process, and the company told me it would be done by 2019, but I don't think it's going to be ready by 2019. It would need, in my mind, it would need to be very consistent. It would have to be point of care where you can almost do the test when they walk in the door. And certainly I agree that $300 would be way too high. Now that analysis was done by a group external to us. So I think more like $150 would be reasonable.
So my colleagues, and I've given up trying to convince them not to order CTs because they always think of a reason by abusing the rule, which is, that's the way doctors are. So I'm skeptical that there'll be any more, and we can get a CT like in 30 minutes. So, that's a challenge you're going to have.
Absolutely. I agree with you. And as I said, until it's in clinical practice and clinicians use it and see if it's useful or not, we won't know.
Okay, thank you. Second mic.
Hi, Nate Shapiro from Boston, Mass. Just a quick comment and then a question. The comment is, I think there might be some utility, obviously, outside the emergency department setting when CTs aren't available. The question is I wonder if there's not, and this would be hypothesis generating, but if there's not complementary information here. And if you've looked at how the CT rule may be complemented by the biomarkers, and it specifically is a CT rule identifying patients the biomarkers miss, and conversely are the biomarkers identifying patients that the rule misses.
Yeah, that's a good thought, and I've actually tried to do that, but as Dr. Steele pointed out, the sensitivity we got was so low it doesn't seem to help, and I've kind of played with that a little bit, and what I think I'll do is kind of bump that up a little bit, like just randomly change it to try to reach a sensitivity of, let's say, 90% for the Canadian CT rule. What I will tell you, and again, I haven't read the paper in depth enough to understand exactly what they did, but the economic analysis suggests just that if you use the biomarker followed by the Canadian CT rule, and that's using quoted sensitivities from the literature, that they may be complementary. So that's an excellent suggestion.
Hi.
Time for one more. First, Mike.
Ted Melnick from Yale. Very interesting talk, and I think the comparison to Canadian rule is interesting in terms of a rule that we have that performs well and what these biomarkers' roles may be. So I was hoping you could comment on the selection of these particular biomarkers as opposed to other ones that are out there, as well as whether there's been a drive to follow patients out longer, because an area where I see biomarkers potentially performing well is actually in prognostication from the ED, since we already know from the decision rules who may or may not have a clinically important brain injury, but we really don't have the ability to predict who's going to end up with a concussion or long-term concussion sequelae.
Don't get me going with the concussion. When the FDA announcement came out for this, their thing was, now there's a biomarker for concussion, and it's anything but. These biomarkers, if you look at averages, on average, normal controls are very low. Orthopedic controls are a little higher, meaning somebody that may have broken a bone but didn't have a clear-cut head injury. People with head injuries with no bleeding are a little higher. People that have head injuries with bleeding are the highest on average. The crossover is huge, so it's very difficult to know exactly how these will work in those situations. This was very specifically designed and, frankly, mandated by the FDA to look at CT positive versus negative. I think if we looked at CT positive versus nobody, there would definitely be a bigger stratification. But I think also, as you alluded to, following these over time may turn out to be useful, and a lot more work needs to be done on that aspect.
Thank you, Dr. Welch. This concludes our plenary session. If I could ask you to join me in a round of applause for all the presentations.